Welcome everyone to the data call webinar for the Healthcare Cost Transparency Board, our inaugural data call. I see a lot of familiar names here. We very much appreciate your attendance. And of course, this webinar will be recorded and posted on our website where you can access it in the future. So my name is Annalisa Gellerman. I'm the Healthcare Cost Transparency Board Manager, and I'll be talking to you about our agenda today. I'd like to welcome you. To clarify, this training is intended to assist technical staff of submitting entities who will be responding to the benchmark data call. And the purpose is to provide an overview of the submission guideline. There is time for questions at the end, but I also encourage you to ask questions throughout the presentation. Our two presenters have quite a bit of expertise and will be happy to clarify anything that you'd like to ask. This training is being recorded. As I said, it will be posted on the Healthcare Cost Transparency Board website. There will be a landing page called Benchmark Data Call. This should be live. I'm hoping it will be live Friday. There will be links there to this presentation as well as to materials you should have already received, the technical manual, the submission template, and materials that are being developed, the FAQs, some of them based on questions you'll ask today, and of course, additional office hours. We do have a couple set that we'll talk to you about later, and we may be adding more if there's sufficient interest. Today, I'll give a brief overview of Washington's healthcare cost growth benchmark. Most of you are probably very familiar with it, so that will be a very brief presentation. Then I will turn it over to our colleague from Baylor Health, January Angeles, to talk about reporting and attribution. And then to my colleague, Ross McCool, my fellow staffer here at HCA, to talk about the data submission template overview. And you see there's also questions and answers and insights that you might want to have, comments you might want to make for us at the end. I'd also like to welcome, I mentioned both January and Ross, but I'd like to welcome Jingping Zheng from our from Healthcare Authority as well. She and Ross work closely with me on this project, so thank you for coming, Jingping. So the overview of Washington's healthcare cost benchmark program. As most of you know, this was established in 2021 by the legislature, and it charged the board with doing these activities: establishing a healthcare cost growth benchmark, also called a target for target percentage for growth, analyze total healthcare expenditures, identify trends in healthcare cost growth, and identify entities that exceed the healthcare cost growth benchmark. There's a tremendous amount of additional information available online, and I've shown you the website there. And if you have any questions about that, feel free to reach out. The Healthcare Cost Transparency Board itself is governor appointed of agency and purchaser representatives. The membership of that committee is set in statute, as well as the members of some of our committees. So, and they are, again, purchasers and major agencies with a role in healthcare regulation. They're advised by two formal committees: the Advisory Committee on Data Issues and the Advisory Committee of Healthcare Providers and Carriers. Again, the Advisory Committee on Data Issues is set based on the expertise of members who sit on that committee, and the Advisory Committee of Healthcare Providers and Carriers is laid out in statute, and has representatives from most of the major provider associations in the state of many different types and most of our major carriers. The board is also required to report annually to the legislature in August. The Healthcare Cost Growth Board has set the benchmark for Washington State, which is the annual rate of growth target for total healthcare spending. As many of you know, this is based on a methodology that considers historic median wage and gross state product. And here are the benchmark values as calculated for 2022 through 2026. I'm sorry, I went by that. This is the annual healthcare cost benchmark cycle. So as you see, we are in the beginning of that cycle, measuring performance relative to the cost growth benchmark. This is, of course, our first year. We call it our baseline year, and you will hear more about that and understand more about it later in the presentation. Then we move to analyzing spending, to understand cost growth trends and cost growth drivers. We will report on both the benchmark measurement and cost driver analysis to the legislature. We will identify opportunities and strategies to slow cost growth and implement those strategies. And this is an annual cycle that does not have a sunset. So these data calls will be an annual event for some time to come. This is our filing submission schedule for this year. As you know, filing opens on August 15th. Final submissions are due on October 1st, 2022. A reminder, that is a lengthier time than you often see for data calls. It is specifically to leave time for resubmission. In this first year, we are all learning, and we want to be able to receive your submission, find any issues with it, have a conversation with you, and have you resubmit in that window. So please don't wait until the end of the period to submit. With that, if there are no questions, and I don't see any, and please, I am looking at, and I also, which is enabled for you, and I also respond to hand emojis, as do other staff. So you can either ask a question in chat or you can raise your hand with a little reaction slide. And I am now going to stop sharing my screen and turn it over to January Angeles to begin her presentation on reporting and attribution. January. And January, you're muted. We can't hear you.
It would help if I unmuted myself. Thank you. Sorry about that. Please let me know if you're seeing the slides, because I cannot see the Zoom as I'm presenting. Hi, everybody.
It looks good, January. Thank you.
Great. Thank you. Hi, everybody, and welcome. As Annalisa mentioned, my name is January Angeles, and I'm a consultant with Baylor Health, and we provide support to Washington, as well as a number of other states that are implementing a cost growth benchmark. So for this session, I'm going to go through parts of the actual data request. I'm going to start by talking about some of the general parameters for the data, and then I'm going to turn it over to Ross, who's going to describe the actual data elements and the template. And everything that we're going to cover today is described in detail in the technical implementation manual that HCA sent out earlier this month, which Annalisa mentioned. Again, that document has information about the cost growth benchmark program, including how performance against the benchmark will be calculated, who is required to report data, what data we will be collecting, the timeline and process for submitting the data, as well as the description of the data submission template. I do want to note that these data states, as much as possible, we have tried to align the requirements to minimize the data collection and reporting burden for carriers that are in multiple states. That being said, each state is different, so you will find that there is still variation in the data requests from one state to another. Okay, so let's talk about some of the general specifications. First, spending data will need to be reported for all individuals who live in Washington, regardless of where the service was delivered or the situs of the member's plan. HCA is collecting claims and non-claim spending. And for claims-based spending, HCA is asking for the allowed amounts based on the date that the claim was incurred. We also ask that you only report spending on claims for which you were the primary payer. That being said, members should not be excluded from reporting just because they have other coverage. And then finally, there should be a claims run-out period, as well as a non-claims reconciliation period of at least 180 days. We know that sometimes it takes longer than that for claims to come in and for non-claims to be reconciled. So in the specifications, it does say that carriers should apply completion factors to estimate spending for claims that have been incurred but not reported, and for claim spending that are expected to be reconciled after that 180-day period. HCA seeks to collect spending on services that are part of a comprehensive medical benefit. And this table details what types of policies you should be including in your reporting of commercial Medicare and Medicaid spending. And so for commercial policies, that includes fully insured and self-insured plans, short-term plans, state employee plans, as well as the contracts with the Federal Employee Health Benefits Program. For the Medicare market, you should include various types of Medicare Advantage plans. You should not include Medigap. And then for Medicaid, we would expect that carriers would include Medicaid and CHIP managed care contracts that they have with the Washington Healthcare Authority. And this table here lists the types of policies for which spending should not be reported. These are what we generally consider as limited benefit plans, things like accident policy, vision only policy, or dental only policy, stop loss plans, and again, supplemental insurance. These are the types of spending or policies that we ask carriers not to include in their reporting. Something to note is that spending will need to be reported by large provider entity, and this table here lists the medical groups or health systems that HCA has identified for reporting. Currently, there are 33 large provider entities, which are listed here, along with state designated codes to identify each large provider entity. The state wants to capture spending on all members, but there will be times when spending cannot be attributed to a large provider entity. And so there's a category for that unattributed spending, and that's been assigned a code 999. This is where that unattributed spending would need to be reported. And then there are times when the state asks for spending for the carrier overall, not broken down by large provider entity. And so for that, there's a code of 100 that needs to be entered there. Something to note is that, to report spending at the large provider entity level, carriers are going to have to go through 2 levels of attribution. First, members would need to be attributed to a primary care provider. And then that primary care provider would need to be attributed to a large provider entity. And so the specifications in the manual indicate that carriers attribute members to a primary care provider using the hierarchy that's outlined here. So first, members who were required to select a primary care provider by plan design, they should be attributed to that primary care provider. And then if there's no PCP selection, carriers should attribute members to a PCP based on existing contractual arrangements. So for example, if a carrier has a total cost of care contract with a large provider entity, and there's an attribution methodology that is used as part of that total cost of care contract, then the carrier should use that methodology to do the attribution for the cost growth benchmark data submission. And then if there's no member selection and there's no contractual arrangement on which to base attribution, then the carrier can use the member's utilization history. When using members utilization history, I think HCA does not dictate the specific methodology, but does ask that carriers apply a methodology that is primary care based. And then once members are attributed to a PCP, that PCP needs to be attributed to a large provider entity, as I mentioned earlier. To attribute PCPs to a large provider entity, carriers should use your existing contracts. So that is, if you have a contract with one of the large provider entities in the list, you should use the list of physicians who are listed in those contracts. We recognize that the participating physicians within those contracts may change for each carrier over time, and that each carrier may have different contractual relationships with providers within these entities. And therefore, the roster of specific providers that are attributed to each large provider entity may be different from carrier to carrier. That is a known limitation of this methodology, but it is one that, it is the methodology that we have. And unfortunately, in many states, we get asked whether there's a provider directory that carriers can use to do that attribution of PCPs to large provider entity. We understand that that is what many carriers would prefer. It's something that we're looking into, but we have to rely on carrier contracts to assign PCPs to large provider entities. So these are the general parameters for the data submission. I'm happy to take any questions if there are any, but also happy to wait till the end. So there is a question here of, can we get a list of tax identification numbers to include for each large provider? Right now, we do not have tax ID numbers that are associated with the large provider. We can see if that is something that we can provide, but currently that does not exist, or we don't have that. Are there any other questions? Please feel free to enter it into the chat or raise your hand and unmute yourselves. Okay. If that is the case, I'm going to stop sharing and I'm going to turn it over to Ross, who's going to walk us through the data submission template. Make sure you unmute yourself, Ross.
Thank you. Okay, so like January said, I will be going over the data submission template and talking about how we would like the data stratified. So first, an overview of the sheets you'll see in the template. We are asking for 5 tables to be filled out. The 6th table is a reference table, which will have things like the large provider entity codes, as well as a few other codes we would like to be used so we can avoid having to do text matching and that sort of those sort of processes for submission. So the first tab will be the cover page, and the cover page will ask for contact information for who we should contact if you have any questions about the submission, especially as we go along with our validation process. Then the rest of the cover page includes things such as asking questions about data completion, as well as what estimates were used, just so we know and can keep track of that kind of information, especially when we're trying to compare the benchmark across the entire state. And then finally is a attestation where it's simply asking that this is accurate to the best of your knowledge. Moving on to the TME tab, which is total medical expense. We have it separated out, and you'll see the template looks a little bit like this on screen. At TME 01, the type of information that should be in that column, so code, and then carrier code. And so there'd be a table in the reference page or the reference tab that will have your particular carrier code in there. Please put that in for TME 1. And then the rest of these are also codes. However, for the year, we've also limited that to just the 3 years that we're asking for this time around. So we'll just be limiting by the reporting year, the insurance category code. So things like commercial full claims, commercial partial claims, Medicaid, Medicare. And we'll get into more of that in a little bit. TME4 is the large provider entity code. TME5 is the age band code, and TME6 is the sex code. That allows us to do some risk adjustment as we're looking at this data. Speaking of insurance category codes, these are mutually exclusive categories that indicate which business you're reporting for. The two that I want to talk about specifically are commercial full claims and commercial partial claims. So full claims are when you have the entire medical benefit and all the data, but partial claims are when you only hold part of the benefit and part of it is carved out, so with pharmacy or behavioral health. And please estimate partial claims data for which you do not have access to. And you can also make a note of methodology if you want to in the cover page. Going on to some of the other fields for the TME section, we also like the number of member months that the data is for, and then we have several TME categories for claims-based spending. So how much did the claims spending include for these groups? And then TME 16 through 21 is several non-claims based spending. We'll go into those in just a minute as well. And then TME 22 and 23 look at truncated claims spending, as well as the count of members who have truncated claims. So truncated claims is more of what we're going to be using for evaluation against the benchmark. And we want to know how many people were truncated at the truncation levels we have. And the truncation levels can be found in the manual as well. Now there is one exception to all these non-negative numbers you see. TME 20, non-claims recovery should be a non-positive number instead of a non-negative number. Just wanted to point that out because it unexpectedly flips. All right, so going through the claims-based categories, we have hospital inpatient as well as hospital outpatient. So we like you for hospital inpatient include payments for emergency room services when the member is admitted to the hospital in accordance with your payment rules, but please do not include payments made for observation services or physician services provided during an inpatient stay that have been billed directly by a physician group practice or individual physician, or inpatient services at non-hospital facilities. And then for hospital outpatient, the sum of amounts for the claims for hospital outpatient service includes all hospital types and payments made for hospitals, including their satellite clinics, emergency room services not resulting in admittance, and observation services. Please do not include payments made for physician services provided on an outpatient basis that have been billed directly by a physician group practice or an individual physician. Then we get into two professional types of providers. The first one is primary care providers. And for this one, we will be using the same definition that OFM used in one of their primary care analyses. This is included in Appendix A of the implementation manual. Attachment 1 includes taxonomy codes for the primary care provider types, and then Attachment 2 includes services that are defined as primary care services. And then for specialty providers, so this will be claims paid to physicians and physician groups that are not defined as primary care. Include services provided by a doctor of medicine in clinical areas other than family practice, geriatrics, internal medicine, and pediatrics. And then we have one more physician group of other providers, and these are claims paid to licensed providers other than a primary care or specialty provider. Also included here would be fees that do not fit in other categories, including facility fees of community health center services and freestanding ambulatory surgical centers. Next up, we have long-term care. And so these will be claims paid to healthcare providers for skilled or custodial nursing facility services, intermediate care facilities, and services for persons with developmental disabilities, hospice, and providers of home and community-based services, including personal care, chore services, delivery meal programs, all of those things that are included in long-term care. Please do not include payments made for professional services rendered during a facility stay that has been billed directly by a physician group practice or an individual practitioner. All right, and then we have retail pharmacy. So all the claims paid to retail pharmacies for prescription drugs, biological products, or vaccines. It should not include claims paid for pharmaceuticals under the carrier's medical benefit. So pharmacy payments made under the medical benefit should be attributed to the setting in which it was delivered. So Medicare Advantage carriers that offer standalone prescription drug plans should exclude standalone PDP spending from the reporting. And it should be, and pharmacy data should be reporting gross of applicable rebates. And then we have an other category, and so this is the allowed amounts of claims paid to healthcare providers for medical services not otherwise included in other categories. All right, then.
Ross, before you move on, I just want to mention, you may have noted upon reading the manual that these various categories of claims-based spending, none of them except for primary care are defined at the code level. They are all kind of descriptions. And so we do not have code level. I think you're going to have to kind of make a judgment of where certain codes fit based on the description that's been provided in the manual. And if there are questions about how to categorize a particular particular service, I think the best approach would be to reach out to HCA and have a conversation about that. So just wanted to make sure that was clear. Except for primary care, everything is sort of description. Only primary care has a code-based definition.
Thank you for pointing that out, January. Then we'll move on to the next type of category of non-claims based spending. And so the first category for this is capitation or bundled payments. So all non-claims based payments made to cover healthcare services, including capitation, global budget, case rate, episode-based payments. After that, we have performance incentive payments. So payments made to providers for achievement of specific predefined goals, such as for quality or cost reduction. So pay for reporting or pay for performance. After that, you have population health and practice infrastructure payments. All payments made to providers to develop capacity and practice infrastructure to help coordinate care, improve quality, and control costs. And then the last three for non-claims based spending are provider salaries. So any payments you make to the salaries of providers. Recovery, or the recovery category, are all payments recouped during the measurement year as the result of prior review, audit, or investigation, regardless of the time period of the initial payment. And again, this is the field that should be reported as a negative number. And then we have an other category as well for any other non-claims based spending fields that may be included in this. This includes things such as governmental payer shortfall payments, grants, and other surplus payments. And then going on to the last two columns will be truncated spending fields. So one of those will be the count of members who have truncated claims, and the other one is the total total spend in that row for claims-based spending that is not that is truncated. Excuse me. And so we have truncation on a per member basis. So we like you to do truncation per member. And we have the different levels to truncate on here is also in the implementation manual, where for Medicare and Medicaid is at 125,000 per member. And then for commercial, it's 200,000 per member. So we would like all payments spent on members after truncation has been applied on a per member basis. And this is the only column that will have truncated spending. Truncation should be applied to the individual's total spending, inclusive of all medical and pharmacy spending. For carriers that are reporting insurance category 4, the partial claims category, the member level truncation should be applied after estimates of carve-out spending have been made. So the truncation is being applied to an estimate of the individual members' total claim spending. I'll wait just a second in case there are any questions about that. Do you have a list to share for taxonomy codes, procedure codes? Oh, I think you answered that question already, January.
Yeah, so taxonomy codes, procedure codes to define PCP visits, specialty visits, other professional visits. So we have a list of taxonomy codes for the PCP, taxonomy and procedure codes for PCP visits, and then kind of a specialty is defined as, you know, non-primary care, non-primary care services delivered by non-primary care providers. But again, the only codes that are available are for the primary care services.
Thank you, January. The next tab we will talk about is the standard deviation tab.
Ross, I'm sorry to go back to the truncation. I think it's probably important to highlight the truncation thresholds because the carriers are asked to report both spending at the provider entity level and the carrier overall level, right? And so there's a method that we call kind of reset the clock approach on the truncation. It may be worth highlighting, just highlighting that, if you will. Or,
yeah, there is a section in the implementation manual that has it's in a box, so it's easier to find, about how to reset the clock, as January states, where we take into account truncated spending if a member is attributed to 2 different provider entities in a year, wherein we look at truncated on a carrier basis, but then also truncation on a provider basis. So resetting the clock is essentially resetting the clock for the providers, but we still want truncated claims for the carriers throughout the year as well. We'll go into that just a little bit more in the standard deviation tab. And I think it might make more sense here because we also have total claims truncated spending. And if you remember back when January was talking about the carrier codes, there is the carrier code for carrier overall, code 100. And so when filling this out, we need an overall code for you for the carriers so that we can get the standard deviation for the spending so that we can look at benchmark values for not just the provider entities, but also the carriers. So when you do the truncation analysis, you'll need to truncate for yourself, but also for the provider entities are reporting on. That was what you were talking about, right, January?
Mhm.
Excellent. So the steps, and this is illustrated more in the implementation manual, but the steps for calculating the standard deviation, we would like you to do it this way, where you calculate an average monthly spend amount of each member using the claims-based allowed amounts. And again, calculating that after you've done partial claims adjustments, and then truncate for member level spending. And just to reiterate, non-claims based spending should be excluded. And then using the per month average multiplied by the number of enrolled member months for that member, and then sum the values for all the members of the group you are calculating and divide by the total member months. And then using the per member per month dollar amount, use that to calculate the standard deviation. And if you're doing this in a formula, please use by the population and not by the population standard deviation and not the sample standard deviation, as that will remove one of the months. Are there any questions about that before we move on? All right, then next up is line of business. For this one, we are asking for the total number of member months by your line of business. This one is mostly filled in for the line of business 02 category. I thought I had an example there, but it will ask you for things such as your those who are enrolled in Medicaid, Medicare, those who are enrolled in student plans or self-insured plans, and it'll ask you that for each of those number of member months for each year. 0 is a valid entry in this if you have no members that are part of those plans or part of that line of business. And then we have the pharmacy rebates tab, where we have the carrier code, reporting year, and the insurance category code. And we have the rebate for both medical pharmacy and retail pharmacy. However, if it is easier for you to just have both of those together, we also have total pharmacy rebate. So if you fill out medical and retail, you don't need to fill in total. If you fill in only total, you don't need to fill in medical and retail. And just to highlight, this is also a negative number. Are there any questions about the pharmacy rebate? And then we mentioned this earlier, but the reference tables will have codes for the insurance categories, the market codes, line of business codes, age and sex, as well as the large provider entities. You'll find your carrier code in there. And we also list the valid years. And then I want to mention a little bit of formatting validation that we have in the template already in it. So if you put in a value that is unexpected, such as instead of using your carrier code, you type in your carrier name, the cell will turn red. And this will be true for all of the fields that require a code. For the fields that require a positive number or a negative number, if the number you entered is not of the expected positive or negative, it will also turn red. So you can do a quick double check to make sure that you for the TME that is opposite of the others, you make sure that that's the correct sign in front of it. So it is at this point I will open up for questions. Several of these questions will more than likely make it into a frequently asked questions document we are building. I also listed insights here to hear from you about things that might make this process smoother. And I know some of you have also submitted data for cost boards in other states. And so some of your insights would be helpful not only to us, but also your fellow submitters. While we get those questions in, I'm going to head and move to the final slide that will list our office hours and ask that you please reserve a time sometime in this time frame and submit your questions beforehand so that we can reserve you a space and just have a meeting with you so that we can go over your questions.
And we'll be sending out calendar placeholders for both of these so that you have it on your calendars. And if there is additional time necessary, of course, we'll arrange that. The purpose of these office hours is one-to-one meetings with you to answer your particular questions and just try to figure out how much interest there is. So please book, and if we need more time, we'll arrange that.
I'll just note that having done this in a few other states and have gone through the whole cycle of data, data submission, data collection, validation, analysis, it's especially in the first year, expect that there will be a lot of back and forth between you and HCA to kind of understand your data submission, make sure that what you have submitted conform to the specifications that have been outlined in the manual. It is not uncommon to have to resubmit a couple of times. I have yet to do it where I think in all the other states I have done it and worked with, they've required all plans to do at least one resubmission. In some cases, some plans or carriers had to resubmit 4 or 5 times. So just for planning purposes, expect that this is going to be sort of an iterative process, especially in the first year. And so we encourage you to really reach out for any questions and kind of initiate a dialogue with HCA to make sure that the submission is follows the specifications that HCA has outlined.
Well, thank you for that, January. And Ross, it looks like we don't have any questions, any immediate questions. Again, you can submit questions at any time to the board email address, which I know that you all have, and we are here to assist you as you look at the submission documents and as questions arise. And we will be posting this. Hopefully our landing page will be ready Friday and you can all access it there. All right, at this point, I think we'll draw the webinar to a close. Thank you very much, everyone, for attending. And we look forward to working with you over the next few months as we do our baseline benchmark data call. Serena, you can stop the recording.